Dr. Nanette Wenger is the next speaker to know how to address you in your own words, also the physician, for those of you who are not here before the public. Dr. Wenger is #1 in the country, both in the world, at women's heart disease, and she's a great speaker, great educator. Most of the cardiologists tell me happy her student. She's the mother of all of us, as I say all the time. And welcome back. Please give a warm applause for the great work she's doing. So we're going to stick to the program and we'll end in time, I'm sure.
Good afternoon. You've just had a very elegant pathophysiology discussion, and I am simply going to tell you a story. I'm going to tell you the story of how we have gotten to where we are, knowing about heart disease in women. These are my disclosures, which have not changed since the morning. And what I would like us to do is to understand the past, present, and future of cardiovascular disease in women, and to appreciate the advances that we've made over the past decade. The theme, if you will, comes from some writings of Victor Hugo, obviously a different context, but he said there is nothing as powerful as an idea whose time has come. And you'll see in a moment why I have appropriated that. One of my favorite cartoons shows a physician sitting across the desk from the woman saying, "We have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anybody." Well, fortunately, this, if you see, was dated 1991. It really has. And I'll show you what the results of sex-specific research have done. Here you see cardiovascular mortality with the women in the dotted line, the men in the solid line. And you see that until the end of the 1990s, the decline in cardiovascular mortality in the US was solely in populations of men, and women's mortality remained unchanged. And then, this is one of my favorite slides. Once we began to see sex-specific information, you will see in the red the mortality in women declining very abruptly, even more abruptly than that for men. And then in about 2013, 2014, for the first time since we began collecting data, cardiovascular mortality in women was less than that in men. And as I said, we are delighted to be in second place, and we hope to stay there. But this is where the story began. And this goes back to 1964. The Oregon Heart Association had a program on coronary heart disease. But what was it called? It was called Hearts and Husbands. This is the first women's conference on coronary disease. And women were taught how to take care of their husband's hearts. Obviously, this was a man's disease. And then when our American Heart Association promulgated the heart healthy diet, what was it called? The Way to a Man's Heart. It was just not thought to be a problem that affected women. And this is back to 1977, when we began to do programs on heart attack in women. And here you see Dr. Harriet Dustin and I presenting, I will call it late night TV. It was 11 p.m. rather than in the prime of the day as occurs now. So I want to go through the steps on the journey. How did we get there? In 1968, at the urging of a number of us, the NHLBI convened a workshop on coronary heart disease in women. And you know, usually workshop to conference, 6 months or a year. Well, it took from 1986 to 1992 until the conference actually happened. And I think there were three things there. We emphasized the flawed assumptions that women didn't experience heart disease until they were elderly, which was not true, and not as seriously at risk as for men. We highlighted the new information that was appropriate for clinical application, but most important for the NHLBI Research Institute, we identified the knowledge gaps that impeded optimal cardiovascular care for women. And because this was published in the New England Journal of Medicine not that long ago, 1993, it did begin to get some traction that really there was a serious problem about heart disease in women. Fast forward to 2001, the Institute of Medicine report, which said exploring the biological contributions to human health, does sex matter? And what the IOM told us is that there was a need for the evaluation of sex-based differences in human disease and in medical research, and obviously translation of this into clinical practice. Then we began to get some clinical trials for the first time. And what you have to realize is that up through the 1980s, it was assumed that women didn't get heart disease premenopausally because they had their hormones to protect them, and that postmenopausally, that menopausal hormone therapy was the cure for everything, from wrinkles to dementia, without any clinical trials. And now we began to get the clinical trials. First was the heart and estrogen replacement study, the WHI, in women with heart disease, and then the huge Women's Health Initiative in healthy women. And what was found? That menopausal hormone therapy did not prevent incident or recurrent cardiovascular disease, and that it wasn't indicated for the primary or secondary prevention of cardiovascular disease. And what this did relative to this conference is it refocused attention on established cardiovascular preventive therapies for women. Then the AHRQ 2003 reported on diagnosis and treatment of coronary heart disease in women, focusing specifically on coronary disease. It was a very good systematic review of relevant research. And what the AHRQ told us, that as recently as 2003, most of the contemporary recommendations for prevention, diagnostic testing, medical and surgical treatments of coronary disease in women were extrapolated from studies conducted predominantly in middle-aged men and middle-aged Caucasian men. And they said there were knowledge gaps regarding biology, clinical manifestations, and optimal management strategies. So this laid out a research agenda, if you will. And then we had the advocacy that was a very important part of this. We had first the National Heart, Lung, and Blood Institute's Heart Truth campaign 15 years ago. It's amazing that it's around this long. And then with it, the American Heart Association's Go Red, which is now the symbol for women and heart disease. And at the same time, Women Heart, the National Coalition for Women and Heart Disease. So we began to see some public information and some advocacy about heart disease in women. And then we began to get some female-specific studies. And this was a women's health study talking about aspirin. And it found that aspirin prevented stroke, but not incident MI in women younger than 65. That was totally opposite the result from the physician's health study, because the physician's health study in men showed that it provided prevention against MI, but not for stroke. And those data still hold up today. Then we began to see some quality improvement initiatives. And this was Crusade, looking at women who had non-ST elevation of myocardial infarction. And what we learned from this registry is that with an acute coronary syndrome, women did worse. They had more hospital deaths, myocardial infarction, heart failure, stroke, and transfusion. And this transfusion will continue to show up with every one of the interventions. Women have a higher bleeding risk. They found that women were less likely to receive coronary interventions and guideline-based therapy, even though they were the higher risk population. And of course, the question that was raised was the worst prognosis biologic? Was it related to a raised baseline risk? Or was it because they were suboptimal admission and discharge therapies for women? And in an editorial I wrote, is this biology or is this bias or is it both? It's both. Then we had a study sponsored by the NHLBI that totally changed the paradigm of the way we think about coronary disease in women. Because as you know, in men, coronary disease is predominantly due to significant obstructive disease of the epicardial coronary arteries. But in the Y study, it was seen that there was myocardial ischemia, as done on non-invasive testing. But with that myocardial ischemia, when these women went to coronary angiography, many of them did not have significant obstructive disease of the coronary arteries. Yet it was the ischemia that killed, and the ischemia was the result of either non-obstructive disease or microvascular disease. And what it highlighted was the importance of microvascular disease and now non-obstructive disease in women. And these are two very active areas for research. And what we begin to realize now is that a substantial number of men also have myocardial ischemia related to non-obstructive disease and microvascular disease. And as I've said, when you study heart disease in women, you are going to get beneficial effects for men as well. Then specific small studies, mostly out of the Harvard group, and the women's antioxidants cardiovascular study, and the antioxidant and folic acid study. And this was the time when antioxidants and folic acid were being used very intensively and widespread as preventive interventions. And what we found out from these studies was that vitamins E, C, and beta carotene did not prevent incident or recurrent cardiovascular disease in women, nor did folic acid and vitamin B supplements. And I will tell you, it was so difficult for me, and I expect for many of you in the room, to persuade the women to give up their vitamins because they were in love with vitamin E and vitamin C and were convinced that this was all that was taking care of them. But the fact is that these were ineffective therapies that were removed from a recommended preventive regimen. Then databases also gave us some information, and this is the Heart Association's Get With the Guidelines database. I found out that women had almost double the mortality with an ST elevation myocardial infarction than did their male peers, but that it was predominantly in the first 24 hours. And looking back at it, in the first 24 hours, the women got less early aspirin, less beta blockers, less reperfusion therapy, and less timely reperfusion, all life-saving. The fact is, it's not that a physician said, I'm not going to treat my women patients as well as the men. This was simply that these ST elevation myocardial infarctions were not recognized promptly, and that the life-saving therapies were not instituted. And this told us that there were major opportunities to improve the gender disparities in care and to improve clinical outcomes. Now, only 9 years ago, the Institute of Medicine report on women's health research, the progress, the pitfalls, and the promise. And they said that medical research historically neglected the health needs of women. And this is what I have called bikini research, because most of the research for women was done on the areas covered by the bikini bathing suit, the breasts and the reproductive system. And when there were shared diseases for men and women, women weren't studied. And the Institute of Medicine said that women's health relates to sex differences, which are the biologic factors, and gender differences, and that is the context affected by broader social, environmental, and community factors. But the IOM told us that major progress in reducing cardiovascular mortality in women needs more attention to quality of life issues, functionality, mobility, and wellness. And rarely are those endpoints in any of the controlled clinical trials that we're doing. Further, the IOM report said women are not a homogeneous group and that there are disparities in the disease burden among subgroups of women, particularly those women who are socially disadvantaged because of race, ethnicity, income level, and educational attainment, and said that the institutes, including the NHLBI, should target research on women with the highest risks and burdens of disease. And then they faulted us as journal editors and said the lack of analysis and reporting of sex-stratified analyses limit the ability to identify potentially important sex and gender differences, including differences in care, and saying that journal editors should require clinical trial outcomes to be presented separately for women and for men. And then obviously translating this into clinical practice and public health policies, and effective communication of research-based health messages to women, to the public, to providers, and public policymakers, some of which is being done at this meeting every year. 2011, we had an updating of the American Heart Association's Women's Prevention Guidelines. And for the first time, what was highlighted is that specific for women, pregnancy complications, preeclampsia, gestational diabetes, pregnancy-induced hypertension are all early indicators of cardiovascular risk. And said, as we said from this podium, that a detailed history of pregnancy complications must be a routine component of risk factor assessment for women. The guidelines also said that there is an increased cardiovascular risk with systemic autoimmune collagen vascular disease. And of course, these predominate in women, and that these women should be screened for risk factors. And as a matter of fact, at our Emory Women's Heart Center, we have one of our cardiologists in the rheumatology clinic where they work with the rheumatologists and see the women, not to address their rheumatologic disease, but the question of do they have concomitant cardiovascular risk factors and should these be improved? Now, for the classicists among us, we will realize the problem of Sisyphus, who keeps rolling the boulder up the hill only to have it roll down again. And that for a while had been the story about heart disease in women. But I think we've begun to see some contemporary help for Sisyphus in this regard. And this is the issue of women in clinical trials. The problem is that women were underrepresented in the mixed gender NIH trials, and even when they were included, were disadvantaged by the absence of gender-specific analyses. And even though women have increased in trials over time, until the end of the 1990s, there were only 20% women in all the acute coronary studies. Cochrane Reviews very recently examined some 250 cardiovascular clinical trials and said that only 1/3 examined the outcomes by sex. And of those 1/3 with sex-based analysis, 20% reported significant differences in outcome between women and men. So it was there, it just wasn't being looked at. And then another concern that I have particularly is that the exclusion of elderly patients from clinical trials, which has been systematic, really doubly disadvantages women because there's a predominant of coronary events in women when they are of older age. And this has been an amazing accomplishment of the 114th Congress, 215, 2016, to show that Congress really sometimes can do something. This was introduced in April of 2015, and it was a mandate by the Government Accountability Office to update reports on women and minority inclusion in medical research, both at the NIH and at the FDA. Previously, there had been recommendations and advisories, but it does not have the mandate of legislation. And the National Institutes of Health had to ensure that both male and female cells tissues, or animals were included in basic research. Until a few years ago, if you asked a basic science researcher what was the provenance of their cells, they had no idea whether it came from a male or a female animal. Now, doesn't it seem ridiculous to be doing research on a female topic on cells and tissues from a male animal? It didn't seem illogical to them, but I think you say this to most kindergarten students. They'll say, that's stupid. Anyway, the results should be disaggregated according to sex and sex differences, and at the same time, update the guidelines, inclusion of women and minorities in clinical research. So now, when you submit an NIH grant, you have to define whether you'll use male or female cells, tissues, or animals. And in the choice of patients, the patients have to at least exemplify the prevalence of disease in the community. So it's gender, race, ethnicity, etc. And you have to show in your grant plan how you're going to accomplish this, or that grant will automatically be triaged. The FDA now has to ensure that clinical drug trials for expedited drug approval are sufficient to determine safety and effectiveness for both women and men, so that this impacts industry. Because when industry comes to the agency and says, well, if we do the trial and we do it this way, are we likely to get approval? Well, there will be the requirement for women and men. There's not an elderly requirement there, but race and ethnicity is. And again, that the safety and effectiveness have to be supported by the results of clinical trials that separately examine the outcomes for women and for men. I want to expand on this before I close just a bit further, because I think if we truly want to expand the landscape of women's cardiovascular health research, what we have to do is have research that includes outcomes of beliefs and behaviors, that includes community issues, local, national, and even global community, that includes areas of economics, of environment, of ethics, of legislative and political issues, of public policy, and society and sociocultural. This is really an expansion of the landscape of women's cardiovascular health research. And this is why I think we have to examine gender differences in cardiovascular disease. And I thank you for your